Okay, let's jump straight in. This deep dive is specifically for you for revision using the notes you've given us. Our mission today, really just pull out those key high-yield facts on a specific topic so you can grab them quickly.
Exactly. And today we're looking at laryngomalacia in pediatrics. Basically, the most common reason infants have that noisy breathing, stridor.
Right, stridor. So laryngomalacia, what is it at its core?
Yeah, so think of it as a structural issue right in the larynx, the voice box.
Yeah.
It's congenital, meaning they're born with it,
Mhm.
and it's where the tissue above the vocal cords is, a bit floppy. It kind of collapses inward when the baby breathes in.
Congenital. Okay, so they're born with it. And the cause, do we know exactly why?
No, not definitively. The leading idea, though, is it's down to immature or sort of floppy laryngeal structures. This leads to that dynamic collapse when they inhale. Some researchers think genetic factors or maybe abnormal development in the womb could play a part too, but
Yeah.
yeah, immaturity is the main theory.
Immature structures. Okay, that makes me think about risk factors. Are there certain babies more likely to have this?
Yeah, good connection. The key things to remember here are premature birth makes sense. Structures might be even less mature. Also, we see it linked with GERD, gastroesophageal reflux disease,
Mm,
and certain syndromes like Down syndrome. Those are important associations to keep in mind.
okay, GERD and Down syndrome,
Yeah.
or prematurity. Got it. Now, the pathophysiology,
Yeah.
how does that floppy tissue actually make the stridor sound?
Right. So it's all about the mechanics of breathing in. When the baby inhales, those structures above the cords, the epiglottis, that flap, and the arytenoids behind it, they get sort of sucked inward.
Pulled in, like closing curtains almost.
Exactly like that. And this narrows the airway partially. Air trying to squeeze past that narrowed, wobbly bit creates turbulence. And that turbulence, that's the sound. That's the high-pitched inspiratory stridor you hear.
Okay, makes sense. Now, stridor itself isn't only laryngomalacia, right? So clinically, you have to think broader. What else could cause that sound?
Absolutely crucial point. The notes rightly highlight other possibilities. You've got to consider things like vocal cord paralysis, the cords aren't opening right,
Mm.
or subglottic stenosis, which is a narrowing below the cords, tracheomalacia, that's floppiness of the windpipe itself, and rarer things too, like laryngeal webs or cysts. So yeah, always run through that differential list.
How common are we talking here? Is laryngomalacia something you see often?
It's relatively common in pediatrics, yeah. Affects maybe 1 to 2% of all newborns. And like we said, because prematurity is a risk factor, you do see it more often in preemies.
Which, yeah, explains why it's the #1 cause of infant stridor.
Yeah.
So what are the classic signs? What would you actually see or hear?
The absolute key feature is that inspiratory stridor, heard when breathing in. And a really important point for revision, it often gets worse.
Worse when?
Worse with exertion, like crying, feeding, or agitation, or even just lying flat on their back. Basically anything that makes them breathe harder.
Right, more effort pulls those floppy
mhm.
bits in more. Any other signs to watch for?
In more significant cases, yeah. You might see difficulty feeding because breathing takes so much work. And that can sometimes lead to poor weight gain.
Oh, and the timeline is pretty typical too, which is useful. Symptoms usually pop up in the first few weeks of life, and then they tend to peak around 4 to 8 months old.
Okay. And diagnosis. How do you confirm it? Is it complex scans?
Actually, diagnosis is mostly clinical, based on that classic history, the type of stridor, when it started, when it's worse, and the physical exam. Often, that's enough.
But sometimes you need a direct look.
Sometimes, yeah. Flexible laryngoscopy passing a tiny camera scope through the nose down to the larynx might be done, usually to confirm it or check how severe it is or if the picture isn't quite typical. Other scans like fluoroscopy or MRI, they're much less common, really just reserved for tricky cases or to rule out those other differentials we talked about or look at the whole airway picture.
And the management. It sounds potentially serious. But how is it usually handled? This is probably the most important takeaway, honestly. The vast majority of cases get better all on their own. No specific intervention needed.
So mostly just supporting the baby while they grow out of it.
Exactly. Management is supportive, focuses on things like making sure feeding is okay, maybe adjusting positioning during feeds to help breathing, and just close monitoring, keeping an eye on their weight gain and breathing.
What about surgery? You hear about surgery sometimes.
It's rare, really reserved for the more severe end of the spectrum. So cases that aren't getting better or where the breathing difficulty is really impacting growth or causing significant issues like pauses in breathing, apnoeas.
Okay, good to know it's usually not needed. Which brings us to prognosis. What's the general outlook?
Generally, it's very good, favorable. Most babies completely outgrow laryngomalacia. As they get older, those laryngeal structures mature, they get stronger, less floppy. This usually happens by about 12 to 18 months of age. The stridor just gradually fades away.
That's reassuring. Are there any potential complications to be aware of, even if most do well?
In those severe cases we mentioned, yeah, there can be complications. Significant feeding problems leading to what we call failure to thrive, not gaining weight properly. Very rarely, you could get severe airway obstruction needing emergency help. And sometimes secondary issues pop up, like GERD getting worse, or even aspiration because of the altered airway mechanics.
Right. So let's boil this down for revision. Key message. Laryngomalacia, #1 cause of baby stridor, caused by floppy tissues above the vocal cords collapsing inwards on the in-breath. But, crucially for most kids, it's benign and self-resolving as they mature.
Exactly. And thinking about that maturation, it sort of prompts a wider question for you, doesn't it? How does this idea, structural maturation, fixing a common infant issue, apply elsewhere in pediatrics? You see that pattern again and again.
That's a great point. Keep looking for those connections. And remember, if you need more focused revision material like this.
Yeah, definitely check out pastthemsra.com and also freemsra.com. Lots of resources there to help you prepare.
We hope this deep dive has given you those high-yield facts you were looking for. Keep exploring, keep learning.